Hello, welcome to another Wednesday live stream, and we are running out of the number of live streams before the exam itself. good to have you all here tonight, and hopefully the week has treated you well. You are ready and rearing to go for another round of practice KFP questions for the RACGP KFP exam next Saturday. That's right, it is coming up super close and we are all going to absolutely smash it, I am sure. Of course, this time of year there are bugs floating left, right and centre, and I myself have picked up another throat bug. Yay, the joys of having kids, which is also why we're a little bit late tonight. Apologies. So we've got a few people in the chat, and good to have you all in here. Let's get started for the night, and of course we have 10 days to go before the exam. We again have confirmed that it's paper-based, so make sure you are practicing with pen and paper. I cannot stress this enough, how important it is to be practicing this now and have your strategy for the exam ready to go. If you haven't been doing this yet, you still have the next week to really smash in and get that down pat. Make sure you know your exam venue, and this is also, of course, the last chance to do things like confirm childcare, confirm any accommodation for those who are having to travel, and what your travel and transport requirements might be. For those that are travelling to a venue perhaps nearby or maybe a few hours away, I would actually take the opportunity even this weekend to actually practice and find out how long it's actually going to take you to physically get to there, and work out any kinks of the transport before the actual day itself. So have a think and see if that's something you would be wanting to do. Of course, we are all here tonight to run through some practice questions. So without further ado, let's smash into it. We'll be putting 2 minutes on the clock. Practice these as you would an actual exam question. And of course, your time starts now. Amy Wilson, a 36-year-old woman, presents to the general practice with complaints of irregular menstrual periods. She also mentions difficulty getting pregnant despite trying for over 1 year. Amy has no significant past medical history and takes no regular medications. On further inquiry, she mentions a family history of diabetes. She is a non-smoker and drinks 1 standard drink 2 nights per week. On examination, Amy appears generally well. She has visible facial hair growth and acne. Her temperature is 36.7, blood pressure is 120/80, heart rate is 80 and regular. Respiratory rate is 16 and BMI is 32.8. The remainder of examination is unremarkable. Amy is determined to find out the cause of her symptoms, what specific features on presentation would confirm the most likely diagnosis. List 3 specific features. All right, how did you all go? Seeing a few answers popping up. Let's run through some potential practice answers for you. So, again, we're looking at what are the specific features on the presentation that would confirm the diagnosis. And from here, we have irregular menstrual cycles. And this is kind of pointing us towards that PCOS diagnosis, over 35 days, or under 21 days, or absent outright. Putting that would give you a full 2 marks. Given the specificity of it, again, we should be looking at what are the particular criteria for diagnosing PCOS we would be using. If you just were to mention things like irregular or absent menstrual cycles without specifying the timeframes, I think you would still get a mark. Pardon me. But perhaps not the 2 marks as you would for the specificity of the timeframes as well. Likewise, we're looking at those signs of hyperandrogenism, so hirsutism or male pattern balding, subfertility or infertility, and as well looking at some psychological symptoms such as anxiety, depression, psychosexual dysfunction, or possible eating disorders, and again, the metabolic features such as obesity, dyslipidemia, or diabetes. Now, we are getting some good answers here of the excessive axillary hair, acanthosis nigricans. So this would tie into the metabolic features as well as hirsutism, and excellent examples of both of those. I can see as well we've got biochemical hyperandrogenism, fantastic. Polycystic ovaries. Again, on ultrasound, you'd be looking for over 10 cysts. Now, the trick here is in terms of reading the question and making sure that's the one you're answering. So this is the what specific features on presentation would confirm. And so I don't think they would necessarily accept polycystic ovaries, even though that's a thing we're all looking for, really. So just be cautious that you are answering the question that is being asked specifically. Here we have hyperprolactinemia. And again, for there, I'd probably, rather than state hyperprolactinemia, I'd specify what are the specific things of hyperprolactinemia you'd be looking for. Colon tolerance, I think, would be a fantastic answer there. And as for being confused by the question, yep. This is, I think, a situation that you might find yourself on the day as well in terms of feeling like you're getting flustered by what it's looking for. And look, you've identified there that, yes, it's likely PCOS. You've identified, yes, we're looking for the Rotterdam criteria. But when it's specifying for the presentation, it's then about trying to niche that down to, well, how would we be applying that criteria there on the day in terms of how that patient's presenting sitting in front of me? Because at the end of the day, we will be coming up with that provisional preliminary diagnosis based on the patient sitting in front of you. This is where they try to let you know that they're not trying to trick you. They want you to be practicing the way you would in the clinic in real life. And knowing that these are the things you are looking for is kind of the direction they want to lead you. Now, an excellent question there about will we score repeating info from the question. For a situation like this, it's asking what specific features on presentation, there it is, would confirm the most likely diagnosis. Now, this is where sometimes the question will be what additional features of presentation would confirm, in which case they're saying don't repeat what's in the STEM. We want new things or new things you would look for. In this case, it's actually safe to be listing some of the things they've hinted at already, because in this situation, the STEM's actually leading you to the diagnosis. And so it's then picking up, well, what are those features there and what other things would you be looking for? So it wouldn't be repeating info from the question so much as confirming the diagnostic criteria that they fulfill. Does that make a bit more sense, hopefully? Let me know in the chat in the comments there. And this is where, again, getting familiar with the specific wording that sometimes is used in the questions makes a massive difference. But look, I'm very happy to say you've all actually narrowed in and you've got the diagnosis. I think it was just a bit of tripping up over the specific answers that were required. You've done it. Well done. And just like in the real exam, if you feel like you've got yourself a bit caught up, wipe your brow, move on. You've still got plenty of other questions to go. And that is where you'll be able to make up any marks that you feel you might lose from not performing as well as you would want on another question. So let's put 2 minutes on the clock and go for it again. You confirm Amy's diagnosis and discuss management. She is keen to become pregnant as her current highest life priority. What management actions would you take to help her conceive? List 5 specific management actions. Doses are not required. And the time is up. Some awesome answers coming through. Very glad to see. And let's run through some of the answers here. First thing is to remember we can address lifestyle factors which are going to have significant improvement in terms of fertility rates, including the benefits of controlling BMI to under 30 to aid fertility. And as I can see, a lot of you have put in there already. That would be very, very important and would score you 2 marks. Likewise, as most of you have got in there, fantastic, commence metformin. So even in the absence of diabetes, for patients with PCOS with subfertility, which having attempted conception for 12 months and not been successful, would be a very, very reasonable step to take. Again, 2 marks. And again, as most of you have put, referral to an obstetrician for consideration of pharmacological treatment or IVF would be looking at 2 marks as well. Part of that as well, and I can see some people have put for investigation of other causes of subfertility, I think that would also be quite reasonable. Again, it's showing that specificity, and we've made little signs, we're going to put them up on the screen. Showing that specificity of you are referring to X for Y. You're showing that not just knee-jerk, I'll refer to this subspecialty because that's vaguely related to the question. You have a specific intent behind it. And I think as long as you're showing that, that's where you'll get the marks. Again, to aid the control of BMI and benefits in weight loss, things like a referral to a dietitian for a calorie-restricted diet would be worth points. Likewise, physiotherapist for weight loss exercise plan. If you were to just say obstetrician without any further things, as we said before, you'd lose that specificity and you would be then finding that you would get less marks. Not necessarily no marks, but less marks. It's similar to all patients where you're talking about conception. You'd be discussing preconception counselling, and a big part of that would be folate supplementation while attempting conception. And we did mention in the STEM, it is mentioned in the sense she's a non-smoker, which is why specifically advised smoking cessation is worth 0 marks. So again, stepping through some of the answers you guys have in here. So commence her on metformin, fantastic. Refer to infertility specialist, fantastic. Regular moderate intensity exercise, 150 minutes. I think that would also be accepted in place of, say, referral to a physiotherapist for a weight loss exercise plan. It's essentially you doing the exact same thing. I will highlight as well, the thing I really like about that answer in particular is that you've specified moderate intensity, 150 minutes, 5 days a week, where you could perhaps tweak it in case it reads as 150 minutes per day, 5 days a week, just specifying over 5 days per week, which I'm sure is exactly what you're talking about. But again, just to avoid any confusion, again, it's going to be clinicians marking this, so I doubt that would take any marks away for that, but just really being a bit OCD on that one. And as you've got there, target or a BMI of less than 25. While that would be ideal in terms of fertility in particular, under 30 is generally the target for patients with PCOS. However, I don't think you would necessarily lose marks. They may just give you, say, 1 mark for perhaps incorrect BMI range there. Again, we have fantastic answers here in terms of commencement of oral metformin, encouraging that weight loss, support ceasing alcohol intake, which is one that's not on here, but I think probably would get you a mark in terms of counselling, in terms of preconception counselling. Consider referral to in vitro fertilisation clinic. Now, with that, I'm going to be a little bit nitpicky again, and I'd say commit. If the patient's sitting in front of you, you're not going to say, I'm considering referral, you're just going to refer or not. And so in this exam, you're showing consultant level knowledge. I would just commit and say referral to a fertility specialist or obstetrician for consideration of IVF. Again, specifying why. And advise her to get partner to get reviewed for fertility too. Excellent point. It wasn't in here. Probably would be worth a mark in the actual exam as well. Again, these are those situations where you may not actually have that answer in the rubric, but enough people put that, and I imagine something like that, probably enough people would. They would be likely adding that to give you marks in the actual exam. Here here, we have weight loss. Again, I would just be cautious to add some specificity to there. So give either a target or a way of doing that. Continue vaginal intercourse for a year. Now, because they've already gone for 12 months, it would be appropriate to consider referral at that point. But as you've just got there in the next line, referral to a fertility specialist, in vitro fertilization, I would be combining those two answers together to give you, pardon me, the specificity back. And refer to dietitian, fantastic. But I would then, again, tie that back. Why are you referring to a dietitian? For meal plan or calorie restriction diet. Arrange OGTT. I would be cautious here because you may be going into what investigations would you perform, and that is unlikely then to be giving you a mark. It would be certainly something you would be considering as part of your workup, but I wouldn't necessarily consider that as a management step. And a question in here as well, wondering if short forms like EG and BMI will be safe to use. So the official answer from RACGP is avoid any abbreviations. The answer from people I've spoken to who actually are marking the exams is a bit of common sense applies. And so the trap they find themselves in is that they can't say what is an approved abbreviation and what's not, because then they're forced to try and maintain lists, and it would just be way too messy for them. So the blanket rule is avoid abbreviations. But if it's very clear in context exactly what you've written and why you've written that, as a clinician marking it, they would be likely to give you the marks, but they can't guarantee it because they can't guarantee that clinician's going to know exactly what that abbreviation means. Sometimes we use, subspecialist knowledge that, or an abbreviation that may be specific to a particular region. And I'm sure we've all worked in hospital settings where people are using abbreviations that are very specific to that niche, and we may be doing that without even realising it, thinking, well, everyone knows what that means, and it may be sent to an entirely different part of Australia where that abbreviation isn't commonly used. So again, I would just be avoiding it as much as possible. Coming up here as well, we have a question regarding the BMI and exercise program. Would you think it is a grouped response? Not necessarily, because while they're ultimately targeting the same thing, I think you would be able to accept a benefits of BMI under 30 to aid fertility that's showing specific knowledge about subfertility and body size. In terms of the exercise program and the referral to dietitian, they're different aspects then of how we're going to achieve that. So they're very related, I agree, but in this kind of instance, they're to target different things. One is the explanation of, and the others are kind of how we're going to get there. But very good question, very good point. All right. Excellent comments coming in, but of course the exam must go on. So let's put another 2 minutes on the clock and we'll get to part 3 for question 1. Your time starts now. And of course, there we go, sorry. Amy returns 3 months later after your last consultation and reports a positive home pregnancy test with her last period 6 weeks ago. She's been following your preconception counselling advice and remembers you advised her to attend for pathology if this happens. Select 5 appropriate pathology tests. All right, and time is up. Let's have a look at some of the suggested answers then. And this is one of those glorious situations where there are going to be more correct answers than options you are given. So lots of things you may be putting in here give you the chance to be correct. And the ones that would give you marks, and this is according to RACGP guidelines for first presentation. And again, there's actually more answers on here that are correct as well that aren't on this list, that just due for spacing and time aren't appearing here. So for FBE, chlamydia urine PCR, syphilis serology, urea and electrolytes, HIV serology, hepatitis B serology, midstream urine for MCNS, dipstick for proteinuria, and with or without microalbuminuria. I can never say that one properly. There's always words that trip us up. Fasting serum glucose, and of course confirming the pregnancy with a beta HCG. And that one in particular being worth the 2 marks, the high marks, given we want to confirm. And as I can see in here, you've all got fantastic answers through. And as you've noticed, oh my God, I was worried about this question, wanted to pick so many. Don't be alarmed if you see this. This is a really, really common thing to see, that often there'll be 2 or 3 or sometimes even 4 more correct answers. They're not trying to trick you. Sometimes you may have to try and work out exactly which ones they are going for, but it is very, very easy. Yes, if you're after for the reference for this, I can post up into the description of the video once it's uploaded the reference that I used when putting this one together. It comes from RACGP, and there's a couple of articles from RACGP as well about first presentation in pregnancy. So I'll share that one up there. All right, without further ado, let's move on to our next question. We'll put 2 minutes on the clock and your time starts now. Michael Snyder, a 65-year-old man, presents to the general practice with complaints of recurrent heartburn and regurgitation of sour-tasting fluid into his mouth. He reports experiencing these symptoms after meals and when lying down. John has a history of smoking, consuming approximately half a pack of cigarettes per day for the last 40 years. He occasionally consumes alcohol. He has no significant past medical history and takes no regular medications. On examination, John appears well. His temperature is 36.8, blood pressure is 130/80, heart rate of 80 and regular, respiratory rate is 16, BMI is 29.3. The remainder of his examination is unremarkable. What is the most likely underlying diagnosis for Michael's symptoms based on the given information? Provide 4 appropriate responses. And time is up. Good to see some answers coming through. And, of course, some suggested answers for you. Common things are common. Again, they're not trying to trick you up. This is a very common presentation in general practice. So the key players are going to be gastroesophageal reflux disease, peptic ulcer disease, esophageal dysmotility, gastric outlet obstruction, hiatal hernia, and esophageal compression or mass or malignancy. That all be kind of grouped together for single answers. So, as you've got there, fantastic to see. And, yep, gastric cancer would be coming into that malignancy bracket down the bottom there. And everything there is fantastic. There was a couple of articles I was reading up when putting these answers together that just cautioned specifying H. pylori infection itself. Go back to what is the H. pylori causing in terms of peptic ulcer disease would be a much more specific answer for KFP. You would potentially get an answer, get a mark for specifying H. pylori, but they would rather put peptic ulcer, and then as part of the workup, you'd be specifying you'd be doing a urease breath test, for example. Hopefully that makes sense. Good. Pardon me. And again, we've got peptic ulcer, acute gastritis. Now, that would potentially be an answer, except for the fact that this specifies that it's recurrent heartburn and regurgitation. And so you probably wouldn't get a mark for that, given the STEM's kind of hinting this is a more chronic, more ongoing kind of condition. But you are kind of right in that it hasn't actually specified a time frame. And so there might be a little bit of leeway if enough people were to all put that answer as well. But again, I think probably the safer option would be to specify something a bit more chronic. Excellent answers otherwise. And again, there, as you've got there, gastroesophageal reflux disease. Nail on the head. Well done. So let's move on to the next part of the question. We'll put 2 minutes on the clock and your time starts now. Michael is reluctant to undergo any testing and would prefer to try conservative management in the first instance. What non-pharmacological management would you recommend to Michael? List 5 non-pharmacological management actions. And time is up. Going to the answers then. We have elevation of head of the bed being worth 1 mark. These are all from RACGP and handy guidelines as well. Now that is, and this has been apparently in exams previously where that has been an accepted answer. There's actually very little evidence, though, to say that elevation of the head of bed is a dramatically successful therapy. But if someone's willing to try conservative management, it is still as part of the recommendations. Weight loss to BMI under 27 or healthy BMI range. Tracking and avoiding trigger foods, beverages, reducing fat intake, avoiding spicy and acidic foods, eating smaller meals. All of those would kind of be grouped into one kind of one group and be worth 1 mark. Avoid lying down or exercising immediately after meals. Smoking cessation interventions, and that's, you'll see, worth 2 marks. That's a big ticket item for this kind of question. And limiting alcohol consumption as well. And seeing these answers coming through, some gold stars there. Absolutely nailed it. Very, very well done. And I think all of those things would be wonderful. Just be cautious with the do a food diary to identify, then avoid triggers of symptoms. That may veer slightly into overcoding territory, given you're specifying two things, one being tracking, one being avoiding. Probably a safer way to do that would be, say, food diary for avoidance of triggering foods. So it's saying the same thing essentially, but in a sneakier way. Sitting upright for at least 30 minutes after each meal. I think any clinician marking this would count that as avoiding lying down or exercising immediately after meals. Would definitely be worth a mark, and encouraging weight loss. Again, as you've got in there, the smoking cessation, refer to physiotherapist for exercise program, losing 5% body weight, fantastic. They may be kind of joined together, so I would just be a little bit more cautious in that one. Avoid lying down immediately after meals, beautiful, and avoid spicy meals. Which really sucks because I get a little bit of reflux myself and I love spicy food, so that one really, really hurts me at a personal level. And again, avoid consumption of spicy foods. Oh, come on, guys, you're killing me. Reduce alcohol consumption, weight loss, sleep at an incline of 30 degrees. So fantastic, you've got the elevation of head, bed, and smoking cessation. Well done, well done. And more gold stars all around, guys. Absolutely nailed this question. Pardon me. Of course, there is a third part to this question, so we'll put another 2 minutes on the clock, and your time starts now. Michael follows your advice and his symptoms resolve. He returns, keen to address his smoking, and after discussion he agrees to commence varenicline Champix. What specific advice would you have on commencement? What 5 aspects do you discuss? Dosing is not required. All right, and time is up. Seeing some good answers coming through, and through to the suggested answers here. So one of the key things is you have to commence this for 7 days before you stop smoking. And that's a very, very important feature to actually get a good effect from it. So because of that, you will be getting 2 marks if specifying. Now, this is one of those medications where we really caution about the mental health effects from it. And there is, it's common practice to advise caution when there's significant mental health disorder alongside. Now, several studies have shown that there is not an increased risk of neuropsychiatric events on patients taking Champix. However, there have been reports of suicide or new or worsening neuropsychiatric symptoms. And so because of that, it's hard to say whether there is an association there, thus the general caution in the medical community. So it's one of those things where the evidence isn't there, but it's made enough people nervous enough to say, look, it's worth having that chat in the first place. So you would get 1 mark for mentioning it, despite the lack of evidence. Just one of those things. Now, of course, monitoring for common side effects, and probably the big one most people are aware of with Champix is nausea, being the thing that often stops people from actually taking it in the long run. But you could also specify vomiting, dyspepsia, constipation, flatulence, abdominal pains, weight changes, taste disturbance. Of course, the abnormal dreams. I've had patients actually request to be put on Champix because they had such weird and wonderful dreams while taking it. To each their own, I guess, and insomnias or parasomnias as well. Taking with food can help reduce nausea as a part of management advice as well, and that's something that actually can dramatically change people's tolerance of it. Given the risk of sedation or dizziness for the first dose, they should be doing it at a time where they're not going to need to drive cars, operate machineries, or do anything dangerous. Dose reductions possible if nausea or other side effects are limiting its use, and success rates definitely increase if you're using it alongside nicotine replacement therapy. Now, once people come off from Champix, there is a period where cravings for nicotine or that withdrawal pattern actually increase, and so you can get high relapse rates following cessation, so reinforcing that when we come off of this, you need to be prepared for that and have all things in place. Smashing the answers there, very good. And yes, specifying the time frames, and that is 100% correct in that you need to complete at least 12 weeks, but potentially add more for full effect. So that would be something that I think would get you marks. Watch out for bizarre dreams as a side effect. Pardon me. Not the most scientific way to put it, but I think any examiner marking that would have a little chuckle and say, yep, you know exactly what you're talking about, and I think you'd be getting the full marks there as well. Quit date to which he agrees to, yep, so I can see here you've made a note. Where was it? Asking about Champix specifically or smoking cessation in general. So this is where, again, being really nitpicky about the question being asked. So asking about Champix, what specific advice would you have on commencement? Ties it into we're focusing in on the commencement of the Champix. What are things specific to that medication? But look, a fair question, and I think if enough people kind of fell into that trap as well, they probably would be looking at rewording it for future use or accepting more broader answers. But yep, as you've got there, if we go back to, we've got that one, here we are. So stop smoking after 1 week after starting Champix. Start using nicotine replacement, fantastic. Follow up in 2 weeks. I think you probably would get marks for specifying a follow-up plan as well, particularly when this is a medication that causes so many side effects. Referral to quit line would actually be part of a structured quit program. And I think if enough people answered that, you might actually pick up marks there as well. Avoid alcohol consumption, though, I think would be unlikely to give you marks. So just be a little bit careful. I do like even reducing as an endpoint is still good, and that's something we definitely should be reinforcing to patients, that even if you quote-unquote fail a quit program, taking those steps and going through that process makes you more and more likely to succeed with subsequent attempts. Now, would model answer 2 be potentially given 0 score since case stem says no past medical history? Now, this is a bit of a tricky one because they often say that they're not trying to trick you. All the information will be in the STEM. This is one of those situations where, because the implications are life-threatening and that things like mental health often aren't discussed, it would be something worth clarifying. And so I think you could argue either way. There have been lots of cases and questions where this exact kind of situation has happened, and one of the expected answers has been to acknowledge one of these major kind of side effects. If there's ever kind of risk of death or serious harm to a patient, even if it's kind of specifying, no medical history, I think it is worth actually reinforcing that you are taking that into consideration. But look, an excellent and very valid point, and a source of frustration for people taking the exam everywhere. Excellent. So, moving on to our third question for the night. Let's put 2 minutes on the clock. And our time starts now. Lisa Kellogg is 25 years old, presenting to general practice with complaints of a rash that started as a single pink patch on her trunk, followed by the appearance of small patches on her arms and legs. She reports that the rash is mildly itchy and has been present for the last 2 weeks. She denies any recent illnesses or exposures to new medications or substances. On examination, multiple oval-shaped, pink-coloured patches with fine scales are observed on her trunk, arms and legs. Her temperature is 37 degrees, blood pressure 120/80, heart rate is 82 and regular, respiratory rate is 16, and BMI is 23.5. The remainder of her examination is unremarkable, and a picture is shown. What is the most likely diagnosis? Provide one specific diagnosis. All right, and time is up. Now, let's have a look at the answers. And of course, this is pityriasis rosacea. We've got all of you getting this one absolutely correct. Very well done. And again, we are going wild on the gold star button tonight. Gold stars all around. Now, pardon me, this is a relatively common presentation for general practice. She's in that classic age group as well. And something to bear in mind on the exam day, that when we get to those questions that have the images associated with them, a lot of us all struggle with the printed version of the images. They're trying to mass produce these books. They're not always done on, shall we say, high fidelity, high resolution photo paper. And so it can be at times difficult to actually see what's in the image, which is why I would reinforce, don't be afraid to then ignore the image. If you're looking at it kind of going, what's going on? Everything you should need to know will be in the clinical STEM. And pityriasis is one of those conditions where it's got that classic presentation of your herald patch that appears, followed then by your smaller oval patches across that classic distribution. And this is going to be pretty representative of the types of questions then you'll see in the actual exam. Without further ado, let's put another 2 minutes on the clock for part 2 of this question. Your time starts now. You give her the diagnosis and she states she's keen to do something to treat the itch, which she is finding annoying. What 4 management actions would you take? Doses are not required. All right, and time is up. Having a look then at some of our answers, we have apply moisturiser to dry skin, showering or bathing with plain water and bath oil or aqueous creams or soap substitutes, not using soap directly, which will dry out the skin further, avoiding sun exposure, a medium potency topical steroid cream or ointment, and I think you would have to specify, pardon me, a medium potency, so you'd be using more of your kind of mometasone type preparations, probably avoiding hydrocortisone as the low potency steroids, oral antihistamines, and look, your flavour of choice is fine. They all have fairly similar efficacy in this instance. There is some evidence for topical zinc oxide or calamine lotions to relieve itch. Now, for more severe cases, you can actually use a cyclovir, can lead to faster resolution of the lesions and help relieve the itching, but only in those severe cases, and so this case wouldn't qualify, and that this is from DermNet. That wouldn't also be aligned with PBS prescribing, so it would be a private script as well. And, of course, for severe cases, you can also refer to dermatology for consideration of phototherapy as well. Again, wouldn't be really applicable to this case here. So, seeing some fantastic answers through there, pretty much nailing it. Wampex over lesions, I don't know if you would be getting much in the way of marks for that one, to be honest, but certainly from a comfort point of view, heat packs are always nice. Again, some fantastic answers coming through here. Again, I like that you've actually specified an example you would use, but I think I'd probably be looking for a more potent steroid than hydrocort in this instance. And look, something that's not on here, but you are exactly right, would be reassurance that it will self-resolve in a couple of months. Because that is ultimately the management of pityriasis. Pardon me. Now, where that does become a little bit more risky is that this is asking for management steps to manage the itch, whereas I guess that's probably more of a reassurance that the itch will go away. You could put it perhaps a little bit risky, but I think given there are other options there, I probably would be looking elsewhere. Again, we've got avoid excessive sweating. Actually, yes, that's not on here, but that is a trigger for itching as well. And I think anyone marking this would accept UV protection with a good sunscreen as part of avoid sun exposure. And yes, very good. Cancelling that to 4 and changing to avoid soap-based wash products. Very well done. All right, let's get ready for... Oh, actually, I might pause here for a second. Deviate from the scheduled program a little bit because there is something that you will see pop up time and time again and exactly on questions like this where they may say, if we were to go back to say the first section here, for this, instead of what is most likely diagnosis, they may actually specify, yes, they do love calamine lotion, I agree. They may actually specify what is your single management action. And that can feel like a bit of a trap of, oh my goodness, okay, I need to choose what is the most important thing. Often if you see that, you're looking at it and you're thinking, oh, this is a benign condition, the actual answer is essentially do nothing. It's reassure the patient that no intervention is required, or reassure is self-limiting and will resolve. Just something that I've picked up from looking at exam question after exam question after exam question, that is a common way they will phrase do nothing is what is the single most important management action. It may specify non-pharmacological as well, but just something to be aware of. All right, coming then through to part 3 of our last question. 2 minutes on the clock, your time starts administering her immunisation. Provide 5 specific questions. right, and time is up. Let's get to the answers then. Now, this is one of those maniacal questions that I swear they must sometimes look at and say, ooh, ha, ha, ha. These are all the things that we should be doing, but perhaps some of us may not be doing it every single time. Now, this is taken exactly from the RACGP immunisation checklist. I'll make this full screen so it is a little bit more easier to read. And of course, these are, is she unwell today? Does she have any disease that lowers immunity? Is she having any treatment that lowers immunity? They would probably be grouped together as a single mark. Is she an infant of a mother who received highly immunosuppressive therapy? Has she had a severe reaction following any vaccine? Does she have any severe allergies to anything? They would probably be grouped together as well. Has she had any vaccine in the last month? Has she had an injection of immunoglobulin or received any blood products or a whole blood transfusion in the last year? Is she pregnant? Does she have a history of Guillain-Barré syndrome? Was she a preterm infant? Does she have a severe chronic illness? Does she have any bleeding disorder? Going back to the severe chronic illness, that may or may not be given a mark, given we've already kind of covered some of the history here. Does she identify as Aboriginal or Torres Strait Islander? Does she have a bleeding disorder? Does she not have a functioning spleen? Is she planning a pregnancy or anticipating parenthood? Is she a parent, grandparent or carer of an infant under 6 months of age? Does she live with someone who has a disease that lowers immunity? Is she planning travel, and does she have an occupation or lifestyle factor for which vaccination may be needed? Discuss with the immunisation provider. So, we've got some excellent answers in here. So, and this ties into have you been unwell recently? Are you pregnant? Have you had an allergic reaction before? And yes, I have to admit I had an evil little grin when I started putting this question together because these are the things that we should be checking every time, admittedly, and often we have the checklist where the patient can just check the boxes as they come into the clinic. But these are the things we should be keeping in the back of our mind. So again, any anaphylaxis to flu vaccine ingredients, fantastic. Febrile illness, are you well? Would be fantastic. Any bleeding disorders, consent to uploading records onto us. Ooh, that is not on here, but I can almost guarantee that would give you a mark if you put it in the actual exam and on any anticoagulants. So very well done there. When was the last influenza vaccine given? And you could actually specify that out to when was the last vaccine you had given, because that kind of hedges bets and covers a few of these things all in one. Any allergic reaction to a past flu vaccine? Fantastic. Any live vaccines in the last 4 weeks? Fantastic. Any current fever? Well done. So yes, this is one of those questions that can trip you out a little bit, and it seems very kind of simple when you think about it, and then when you kind of get to 3 or 4 and you start to think, oh, wait, bother. What are the extra things I could be putting? This is where having a read through of some of the RACGP publications, including, I know we don't have much time left, but just have a flick through the handy guidebook. Pardon me, it's on the RACG website. It is an absolute plethora of information for, in fact, pretty much any what is non-pharmacological management type questions come from there, but tucked into there as well, you'll find stuff like this, the little gems that we often kind of forget to hold on to, forget to really study, and I think they sometimes look at these kinds of questions to kind of make sure we're paying attention to the things we are doing every single day. So well done, guys, getting through another 3 questions. Again, we are just breaking over an hour tonight on live stream. So thanks very much for joining in. Of course, we have 2 more live streams to go. I will be doing another one as a revision session, running through these questions again on Wednesday before the exam. And I'm going to do another one the week after as well, same time as the Wednesday, 8:30, as a post-exam debrief celebration, what to do while waiting live stream. Of course, we won't be able to talk about specific questions, but if those of us mention perhaps aspects of things that we want to discuss, we might be able to have some more anonymized type discussion around some of the things. Again, if you're finding this helpful, I need your help. I am still trying to grow this channel. pardon me, and coughing into the mic is the best way to get more people to actually continue watching. So please spread the word, get this out there. I've decided I am going to keep making these after this exam as well, and just keep building question banks up for people in the future. There is a email list I'm building up as well to kind of keep in touch with people and check in how they're going, how they went in the exam, and if there's any feedback for these sessions as well, greatly appreciated. I will take a moment as well to actually double back to one of the points made earlier on about the gonorrhea PCR for urine on the list of investigations for first presentation for pregnancy. Yes, that was on there. And again, you will actually find questions like that where there are going to be more correct answers than options you can put. Plus, there's going to be things that are correct that don't actually appear on that list. Don't worry. That's often just there's just too many things that could be applicable. They've had to cut some of the correct things off. So they're not trying to trick you or trap you. It's just they want you to be able to identify the things that are right from the things that aren't right. Hopefully that makes a bit of sense. Now, little message to say thanks so much. Being sick, it must have been hard. Look, this is just one of those post-viral cough things. I feel okay, just a little bit hoarse. The famous Mr. Ed, shall we say. Thanks for joining in tonight then. Thank you for all of your time. Yes, I did make them a little bit intentionally a little bit harder tonight than some of the previous questions. Not to be mean, but I think sometimes it's handy to have that little bit of a, make sure you do have your head in study mode for the little sprint just before the exam. I will be going back to the more standard kind of questions for next Wednesday's session so that we're not getting scared before the exam, but just acknowledging that we are getting to crunch time. And I've tried to throw in as well some of the little more kind of trick type questions that do appear from time to time. So just things to keep in mind just before the exam. All right. If there are no other comments, questions or queries, have a great night. Thank you for joining in. If there are any other questions, feel free to pop them into the comments on the video after the fact. And as you've probably seen already, I am chopping up these into smaller videos and releasing them through the week as well. Again, just building up that online question bank for people sitting these in the future. Have a great night, everyone, and I look forward to seeing you all next Wednesday. Thanks very much.